All right. Thank you for sticking around to the afternoon for the sepsis panel. My name's Scott Weingart. Right here, doing our Twitter moderation, is Chris Nixon.
G'day.
And let me introduce you to our panel. Now, these are 6 of the absolute luminaries in the world of critical care and sepsis. So I am not going to give their real introductions, or that would be the entire panel. So I've constrained them to a Twitter-style introduction for themselves. And I'm going to just go down the line in alphabetical order with ladies first. And I will give the Twitter bio, and then maybe they could just say a couple words to introduce themselves, and then we'll go on. So Flavia Machado, intensivist researcher, teacher, deeply involved in quality improvement on sepsis, no relevant personal disclosure. Flavia?
Thank you.
All right.
Hello.
Catherine Maitland, pediatrician, emergency care in resource-limited African hospitals, clinical trialist. Her friends call her Professor Drostioff, which actually is a form of wine, if I'm not mistaken. Yes. And nothing to disclose. Catherine, say hello to the audience.
Welcome.
All right. Simon Fintherer, intensive care clinician and researcher, large-scale clinical trialist. Simon?
Yeah, I'm trying not to become any larger.
Paul Marek, I made yours up, Paul, because you refused to send me one. Intensivist researcher, mythbuster, and status quo destabilizer. I hope that works for you, Paul.
That kind of fits the key, yeah. Thank you, Scott.
John Myberg, intensive care clinician, researcher for 30 years, skeptic, real life playing blues guitar and rowing. John, say hello to the audience.
All true, and it's this American beer, so it's average.
And Mervyn Singer, short, brief, and to the point, intensivist researcher, iconoclast, sex god. So there's our panel. I don't know what I've gotten myself into. We're going to do an experiment, kind of to even the playing field here. Instead of drinking after the session, I actually have my panel drinking during the session, just for a little bit of extra disinhibition and to breed controversy. And they pretty much, as a group, have all mocked North American beer. Each of them, in their response to me, all said, please just don't serve me American beer. So we have exclusively American beers up here. Hopefully they'll meet with their approval. They are quite good. And there's one Canadian, just for my Canadian North American friends. Yes. Woo! All right. Some ground rules before we get started. Please keep it clinical. Research is good, but these folks want to hear what they could do at the bedside tomorrow. Let us know when we move from evidence to experience. Experience is great, but we just want to know the clear delineating line. And then controversy is good. All right, for the audience, if you want to ask these folks questions, the way to do it is Twitter. And just put @PrecordialThump, that's Chris's Twitter handle. And if you hashtag it as SMACCUS, we will actually break the nationwide tweeting statistics. What are they calling that, Chris?
We've got a trend number 1,
there
big
you go.
Spider-Man. Let's do it.
Trending number 1. So a whole bunch of questions were sent in, and Chris and I made some own. The first thing I want to talk about is sepsis identification, because I have no clue. After the recent SIRS papers came out, I don't know what to do. Who wants to field what we should define sepsis as, and what is sepsis 3.0? Do you want to lead us off?
All right. That was a loaded question because I'm involved with it. There's currently a task force which is, it's deliberated for 18 months. Basically, we think SIRS is crap because it's a bit meaningless. Yes? Flavia will throw things at me. We want to differentiate infection from sepsis. So sepsis is bad infection. So what we used to call severe sepsis, we want now to call sepsis, to have clear blue water from bog standard infection, bit of antibiotic, bit of fluid, you get better, you go home, to getting ill. And they're the ones that obviously we need to really worry about because they're the ones who end up dying. And so the idea is to try and have sort of clear blue water. So sepsis, the proposal, so I'll tell you where we are, that we sort of deliberated for 18 months. It's just been endorsed by SCCM and ESICM, the European Society, who are the sort of funding, sponsoring agencies, and it's now going out to all the other big societies around the world for hopefully their endorsement. So the idea is we try and have clear blue water. The only other thing to add is that using big data, So these are large electronic healthcare records, so about 5 million patients worth of patient encounters, about 800,000 of which are having presumed infection, by which I mean they're given antibiotics and have cultures taken, and looking at the outcomes of those and the physiology on the ward, the emergency department. So we've got what's called Q-SOFA. So in other words, if you have hypotension, tachypnea, or an alteration, a change in mental status, then you're sort of highlighted as being at risk. And so that should then prompt more monitoring, more intervention, perhaps referral to critical care, doing the blood test to see do they have organ dysfunction, etc. So that's the recommendations, the gist of where we're going, and I'll shut up now.
Some of the panelists visibly squirming in their seats. Is there anyone who wants to add to that?
So I think Mervin's a sex goddess.
Goddess.
You want to make it simple, stupid. You're making it too complicated. We know what sepsis is. Make it more simple. We don't need a rifle score for sepsis. I think people looking after sepsis know what it is. You want to make it simple. People know what septic shock is, and they know what sepsis is. I think the SIRS criteria are somewhat interesting. That, as the recent paper shows, that you don't need to have 2 SIRS criteria to be septic. But I think a good physician knows when a patient's septic. What I think we need to do is better tests to diagnose sepsis in the ER. That's why I think more research needs to be done to define, is this patient septic, or does this patient have bacterial sepsis, or is this influenza?
Catherine, in your email, you seem to have something to say on this matter. You said we have our knickers in a twist over nothing. Is that fair, or is that misrepresenting you?
Who are you talking to?
Catherine?
What? Sorry, I missed that.
Wake up! How many of those have you had?
All right, this experiment
I
not
already
working.
had one glass.
So, do you have anything to say? Are we going crazy with these sepsis definitions? Should we? Oh, it's Flavia?
Yeah, it's me.
Flavia. Flavia had her knickers in the
I'm
twist.
sorry,
And
I got the
actually-
knickers wrong. It's a hazard I've been through in the past.
It was a lady.
Tell us, Flavia.
Actually, I want to ask Mervin how they're going to diagnose this infection, because the point is how you're going to diagnose a patient with severe sepsis, and you're saying that the beginning of the thing is to diagnose infection. And I think that the SIRS criteria helps you to diagnose infection. Actually, we are using SIRS criteria in all our screening tools, and after that, if the patient are seen by the doctor and the doctor says, oh, there's a possible infection here, then you're going to have your infection. And another problem, Mervin, is that you say, oh, we have quick SOFA, and then we have hypotension, we have tachypnea, and we have reduced levels of conscience. These are already organ dysfunction. These are too late.
Shall I respond?
Yes, by all means.
Okay, we're not, we discussed, it's not our brief to diagnose infection. That's the World Health Organization, etc. And at the moment, I agree with Paul, we need the better diagnostics not only for sepsis and the host response, but also for infection. They're coming along. So at the moment, we're relying on a rather crude, non-specific list of criteria. White cell, useless. Area under curve about 0.6. So it's not that good. So it's what we're doing at the moment, it's an agglomeration of a history, an examination, and some non-specific tests. And then we wait a day or two, and then, oh, hey presto, something grows in the cultures, which is backward. That's the best we've got. So we're not going to try and reinvent that wheel. What we're trying to do is say, right, okay, you need to pick up the patients who are getting worse. Clearly you don't wait till they fall in a heap. But again, if you can pick up the patients early, and then it's a prompt, it's an early warning score, a sniffer, to actually try and make the ward doctor, the emergency room doctor, the pre-hospital care identify that this patient who could have infection actually merits a bit more love, care and attention than perhaps they otherwise would have gotten. So it's a process of care we're trying to encourage, that patients are, you think about, have they got infection that's going bad early, and then you escalate from there.
John, you've made the statement that we are getting we're over-treating sepsis, we're over-searching for it, we're over-investigating it, and we should do less rather than more. Could you tell us how that fits into identification of sepsis?
To me?
Yeah.
Okay. Well, I'm going to take a whole different paradigm, as usual. I think Paul says we know what sepsis is. Well, you have no goddamn idea what it is. If you took a view in this room about what it was, you get different opinions. I would personally prefer it if the word sepsis was taken out of the language. And let's just focus on a couple of things. First of all, we're talking about a syndrome which is largely due to inflammation, which may be due to infection or other para-infective processes. That's hard to quantify, and no test can tell you that. The second thing is it's the impact on the patient which determines your response. In other words, how sick is this patient as defined by how many organs have failed. And for Christ's sake, please don't talk about SOFA, because that is rubbish, okay? The third thing really is, where is this patient in their journey? In other words, what is the natural history of the disease you're seeing? For example, a middle-aged male patient with a UTI, with hypotension, is very different to an elderly patient with community-acquired pneumonia and septic shock. So what's the natural history? What organs can we realistically reverse so that the patient is left with a good functional outcome? And when do we stop over-investigating? So basically, I would like to see a much more pragmatic approach based upon the likely diagnosis in the clinical context, the reliance upon fewer physiological variables and biochemical variables to quantify the organ failures that we see in terms of the intervention intensity we need to get that, and the likelihood of a prompt reversal of that so that the patient is left with a good outcome. Now, no system or guidelines says that. And that's the problem I have with it. It needs to be clinically focused and time contextually based.
Can I chime in?
Please.
So I'm going to agree and disagree with everyone, which is the best strategy. It depends what we're trying to do, okay? I mean, I actually don't think I know you say this is not a early warning score, it's not a severity score and so on, but that's what it is to me.
It is.
That's what it is to me. Yeah, but okay, various other people on your task force keep arguing it isn't.
Yeah.
I mean, that's what it is to me. It's an early warning score, it's a red flag, it's whatever you want. It is not a definition of sepsis.
Correct.
I mean, sepsis, if we're going to define sepsis, and I think it does have some utility, it's organ dysfunction due to infection. That's how it's defined.
Yeah, that's right. Correct.
And I suspect the people on this panel will be very happy with no definition, no scoring system, and the patients would probably do okay. But we also need a system for our nursing staff, particularly on the wards, who are doing observations, and sometimes it's a bit like the rapid response system. One of its major functions is to empower people who don't feel empowered to take action in a systematic fashion. And the same, I think, is about identifying people in the emergency department. If you believe what was published in JAMA, no one dies of sepsis in Australia. This is not actually true. And in New South Wales, there's a program run by the Clinical Excellence Commission called Sepsis Kills. And the reason that program was set up was because 2/3 of the critical incidents being investigated by the health department for unnecessary death were unrecognised, untreated sepsis occurring in New South Wales hospitals. So in Australia, where nobody dies of sepsis, and we have the best sepsis outcomes in the world, apparently, there were still 2/3 of the bad, unpreventable deaths in the hospitals that were investigated as a routine were due to sepsis. So I think we need a definition for clinical trials, which is different from what we need. I've never used SIRS clinically. Yeah. I mean, I was asked by the newspapers to comment on the New England paper about SIRS, and they said, how is this going to change clinical practice? And they didn't like my answer. I said, well, it's not going to change anything, because I don't think anyone who has said, oh look, they've only got one SIRS criteria, I'm not going to call them sepsis, I'm not going to treat them, it just doesn't happen. So we need something for research. We need to have a red flag, which is what you've been working on, and we need to empower people and have systems in place, which I think is what you're concerned about, Flavia, is that we have a trigger that people say, okay, now we're going to do those things. And so I think it has utility, but it's not a definition.
Can I?
Please, absolutely.
Yeah?
Yes.
And I think that you have to stop calling this a early warning sign. For us, in the middle-income countries, this is too late. I think we have a completely different approach. You, in the high-income countries, we have now an excess sensitivity problem, while in the middle-income countries, we have low awareness. So I had already said to Mervyn that this new definition is very, very harmful for us, because people are going to stop thinking about SIRS criteria as a screening tool to detect early septic patients, and they're going to wait for these warning signs, and it is just the opposite that what we're needing now. The mortality rates in Brazil now in ICUs are 55%. Nobody has this. Nobody here has 55% mortality rate in sepsis. So I think that it is very dangerous, and if it's a screening tool or a warning sign, these are going to make us harm.
I think
By all means.
the response I'd give is, I think it's striking a balance. There are, certainly in the UK, there are some hospitals where they have very gentle criteria for calling out a sort of SWAT team. The trouble is now there's sort of call fatigue, because they found that calling them out too often and the patients fulfill the criteria and they were drinking a cup of tea. And therefore you have to reach a balance where you don't want to wait till they're moribund, but you don't want to call your SWAT team out when the patient's drinking a cup of tea. So you need to find that nice balance. And clearly you're looking at trajectory. You know, if the patient is tachypneic and you give them a bit of fluid and their acidosis goes away and they're breathing better, you know you're winning. If they're continuing to deteriorate, you have to escalate. So it's just like everything we do in clinical practice. I agree with Simon. You don't treat somebody because they're septic any different. It's a label, it's a syndrome. You're treating the patient in front of you. You're treating, as John was saying, the organ dysfunction that's apparent and trying to prevent other organs failing. So it's a label for clinical trials, for epidemiologists, but perhaps for calling out the SWAT team, the outreach team, to go and see the patient. But I don't think it's there as, oh, they're not septic, we don't need to worry about them. On the contrary, you do need to worry about them because you don't want them to get ill.
Can I take a
please,
different,
Catherine.
completely different angle on this?
Yeah.
I live and work in Africa. I'm a paediatrician, and Africa is where there's a lot of infection. Yet the guidelines that we follow in Africa are WHO guidelines, and the word sepsis does not appear in that, not a single mention of the word sepsis. So instead we have syndromic management, of the pneumonia, of the diarrhea, and so so when you actually, we've actually do studies, and what I'm saying is based on evidence. When they've done a very, very large case control studies across Africa and also extending into Southeast Asia, this is called the PERCH study, and it's looking at pneumonia etiology. It's not published yet, but I know from the preliminary data that was presented from our hospital on the pilot study, less than 15% of children who have syndromically defined pneumonia will have bacterial. So even where you've got a continent that's full of infection, even those who you think have got bacterial infection, and most of those will not have received antibiotics, actually the fraction who have bacterial sepsis is very few. So we will, I mean, obviously in future we would like to sort of start to say we've got to raise the profile of sepsis and try and drive management towards it. But I think we can learn a lot of lessons from many of the mistakes that have been made elsewhere.
You want to finish this section off, John?
If I could just add to what Kath was saying, I mean, what Kath did in the FEAST trial, in my view, was Nobel Prize stuff. It was a remarkable piece of work. And it really changed the way many people think about these things. One of the titles that she used in her study was the definition of febrile hypotension. I think febrile hypotension in those patients really summed up what it was. And this whole notion of syndromic type diagnostic criteria is very powerful when you can draw on the experience from trials like FEAST. That's a critical thing. And it's also important really to put the context, as I said beforehand, of where the patient is in that journey, in that presentation. The acute phase coming to the ED, the patient who's 2 days post-operative, the patient who's a week into their ICU illness. They're different beasts. They're different people. They require a different response. You cannot apply a one-stop shop, a whole hierarchy of therapies, most of which are homicidal, to fix the problem. It needs to be tailored for the patient and the context.
You want to sum this up, Chris?
Yeah, so I've been having to work pretty hard actually while you guys have been talking away. I reckon I've had over 500 tweets. So I may not be able to name names as I go through this, but it's really interesting how the hive mind of the Twitter sphere was even anticipating your discussion as it progressed. So there were people saying, obviously just waiting for Simon Finford just to chime in and say it's infection plus organ dysfunction, get with the program. But there's also been concerns about, we do need a research definition, we do need a clinical definition. Is it going to apply to all regions? Is it going to apply to all ages? And and then just maybe a sense of there being a never-ending circularity to this question, and will it ever be resolved? Which maybe means we should go on to the next question.
Indeed, and it's taking this to the next step. We are now, I think, at a loss for a global definition of what is sepsis, and we maybe have red flags, and we maybe have screening criteria, but what we really want to know is to treat the patient who is sick, and we hear it's sepsis plus organ dysfunction. That makes sense, though how to define that is tough at a quality level. But what about lactate? Is there still a role for lactate screening? And maybe some people on the panel have some comments on this. Whoever wants to jump in first.
Merrick.
Yeah, I figured that would go that way.
Yeah, so where this notion comes from that lactate is a sepsis test is BS. I mean, it is just a severity of illness marker, has nothing to do with sepsis. It's not due to anaerobic metabolism, it's just a stress response. And to include it in the diagnostic markers is ridiculous because you can be septic with a normal lactate and you may have a raised lactate and not be septic. I don't think it's a good sepsis test, and I think it's an outrage that we're being forced to use it as a marker of sepsis.
Are they using it as a marker of sepsis or a marker of sepsis severity? You want to say something, John?
Well, suffice to say that I violently agree with Paul. The lactate debate has really frustrated me for many, many years, mainly because of the work that I've done in catecholamine research and what it all means. I mean, it's probably the most misunderstood and misapplied marker in our current practice. The oceanic stupidity has been increased by point-of-care analysis. So that now every person, certainly in my hospital, working in the ED or the ICU or the OR, can do a lactate every 20 minutes. And of course it fluctuates up and down. It changes for a whole bunch of reasons, most of which are part of fight and flight. It's got nothing to do with anaerobic metabolism or as a resuscitation endpoint or an endpoint by which you can titrate therapy to. Again, it's just incredulous that this gets permeated. And gets permeated by guidelines with good intentions which are based on a misunderstanding of bad research. So it is very frustrating, and I think it has a role perhaps as an indicator of severity of illness, a bit like tachycardia or tachypnea or perhaps temperature or white cells up or down, the SIRS criteria, whatever that is. But that's where it should remain. But this religious addiction to using lactate as the driver of all things good, to titrate therapies, to back on, back off, is frankly stupid.
You had a reply?
I'll partially defend it. No, so they're right. It's not a marker. It's non-specific. It's a marker of physiological stress. So the more stressed you are, the higher it goes. If you respond quickly to the treatment, the lactate goes down. So the benefit of lactate, as I see it, is the way the disappearance of a high lactate is a marker that you're probably going in the right direction. Probably. The patient is less stressed. So I think that's the utility of lactate. I think there are to be fair to lactate, are quite a few studies out there where people have fairly normal hemodynamics, but the lactate's raised. And epidemiologically, you put all of these patients into a pot, the people who have the higher lactates generally do badly. It's the association, it's not cause and effect, but it's just a marker of the physiological stress that the routine things we measure, the blood pressure, etc., doesn't show. So I think personally, I agree it's a bit overrated, but at the end of the day, I think it's a barometer, a bellwether. And so I wouldn't want to get rid of it just yet.
Let's go down the line. Just a yes or no answer here. Has screening of lactate, not lactate trending, not serial lactates, has screening of lactate saved more lives or hurt more people? John, saved lives or no? Yes or no?
Impossible to say yes.
Hedge. Catherine.
I live in a place where nobody can have the luxury to do that, but it's a very good prognostic marker, so it can identify a sicker child, and that's important.
Simon?
I'm not sure how much harm it's done. It's an indicator, a non-specific indicator of being ill.
Yeah. Flavia?
Teaching people to collect lactate in every patient that is suspect of having severe sepsis save lives. I have no doubt about this. I'm not sure about the physiological thing. I can spend 1 hour debating with my residents if it's adrenaline or if it's hypoxia, whatever. It's a marker of severity, and it has to be in any screening tool for sepsis.
Beautiful. Paul, I don't know which way you're going to go on this one.
Yes, so that kind of creates somewhat of a dilemma. So it's a marker of illness severity. I don't think that's what it is. Generally, if it's going down, the patient's getting better. But you know, there's a doctor at the bedside who looks at the patient and can examine a patient. That's the most important part of the whole equation. There's no test that can replace a smart physician at the bedside who uses his brain and doesn't follow stupid algorithms that he doesn't understand, because algorithms make stupid people even stupider, and as Scott said, they make experts even stupid, because you do things without thinking. You check off boxes without actually knowing what you're doing. So you just got to examine the patient. You know, it's amazing what you can do in Africa just by examining a patient, and you get so fixated on the lactate, you actually forget that there's a patient attached to all your lab tests. And we're obsessed by making every lab test normal. The calcium's low, you normalize it. If the sodium's high, you reduce it. White cell's high, we bring it down. We so practice euboxemic medicine, but there's a physiological reason why it is. Just let nature do its own thing and don't screw with what you don't understand.
All right. Mervyn, you have the last word on this one?
I'm with the majority.
All right. There we go. A question came in from Twitter, and I think it's worth addressing because Paul's now opened the door. We have 6 of the world experts on sepsis here. Why are the Surviving Sepsis Campaign guidelines and our government's response to them here in the U.S. so wrong-headed and so antithetical to all the things you folks are saying? Could someone field that and help me out on this, because I'm really confused?
Maybe I'll chime in, because I was very, very supportive of Phil Dellinger's efforts. I thought the first iteration was an exercise in bringing the world together. And one of the things I really do believe very, very strongly is that we are more than the sum of the parts. When we work together, whether it be small teams in our hospitals doing resus, whatever, or large research communities, or the whole world getting together, then we achieve so much more. So the first iteration I thought was great. It was an exercise in that. The second iteration, which we did not endorse in Australia and New Zealand, and we actually took an official position that we would not endorse them, because we thought, and published on that for the reasons, because we thought there were quite a number of things in there that were likely to be plain wrong. And of course, research has shown that that was the case. And the trouble is, once you write a guideline, it becomes a treatment standard, and then it becomes, falls into the hands of lawyers, and people feel compelled to do things that they think are actually wrong, because they're worried that they're going to be criticised or even sued. And New South Wales, you'll be pleased to hear, is second only to the United States in the number of doctors who get sued per head of population. So we actually took a position against them. The next iteration, which we're currently working on, is slightly different. And I think it's a bit like your ATLS argument. You're writing a guideline for non-experts to deal with something that experts should be dealing with.
There you go. Well, I think we can leave that there because that's the perfect answer. Let's go on to something that...
Yeah, we don't care what you guys think.
Oh, you want to say something about it?
Flavia's going to defend
All
it.
right.
I have
was
first
hoping.
disclosure myself as being an author of the last recommendations. So I was deeply involved on this, and I agree with everything that you said, Simon, that this is not made for experts. I agree completely with the ATLS thing that Scott just told us this morning. But the Surviving Sepsis campaign has a major role in the middle-income countries, where education and knowledge transferring are very difficult to deal with. And if you have a guideline for the regular physician in the emergency departments in the middle of nowhere in Brazil, it's a good thing to do. I don't need the Surviving Sepsis guidelines to run my ICU because we are experts. But I really think that they are helping. Maybe not you, but I have no doubt that it's helping us.
So this is a really important message that from Flavia and also from Kath, that these things are very context specific. And the real, we have developed a whole heap of stuff in academic medical centers in the US and Europe and Australasia, and then thought, well, the rest of the world, either we don't care about them or they should just do what we do, and it's wrong. And hopefully through Gates and Wellcome and so on, we'll see much more being done in the context, because most of the burden of disease, of sepsis, is in low middle income countries. I know that may not be how you guys want what you need to know to treat your patients, but certainly my focus and some of the organizations that I have been involved with Flavia, and that's the focus there, because if we want to actually reduce the global burden of sepsis, we have to go to work in the lower middle income countries, not in Sydney, not in Melbourne, not in Chicago.
You still want to practice the highest level of care. You don't want to reduce it to the lowest common denominator, because then you have people who shouldn't be treating sepsis treating it. And I think the guidelines should be such they should be safe even in resource-poor countries. And I think the guidelines don't do that. So I think if you apply these guidelines to African situation, it may be harmful. So one has to be really careful that it's encompassing, but it doesn't harm the patient. First, do no harm.
I mean, that was why we set up the FEAST trial. At the point when we started the trial, excuse me, most of the hospitals we were working with were not giving fluid boluses. So that was standard of care. As the trial progressed, the doctors got more and more confident. To begin with, they were very scared about giving fluid boluses. And so the trial was stopped early because the DMC viewed the original position as standard of care was no boluses. If that trial had been run in America or UK, whatever, they would have not stopped that trial because they knew it would not have changed practice. The fact that it hasn't changed practice even in Africa, because WHO have not actually changed their guidelines. This is 4 years later, is a disgrace. But we wanted to do the FEAST trial because we were concerned about just simply rolling out what was standard of practice elsewhere in hospitals that have no access to ICU, and that was making doctors very nervous.
Chris, why don't you summarize this
so a couple of quick highlights from the Twitter sphere. So I think the most popular quote that's been retweeted so far is, "Algorithms make stupid people stupider. They even make experts stupid too." So well done, Paul Marek. You're in the lead there on that one. Jason Boitnott reckons he's summarised the entire panel discussion so far as raging against the machine of forced cookbook medicine. I'm sure you all like that.
Well, maybe not Flavia, but let's move on to something that's totally not controversial. It's just intuitive that we give antibiotics for patients who are infected. And yet, the data is kind of sparse, and the data that is there just tells us once patients become hypotensive. And yet now, in the US, we have governmental regulations starting a clock to give broad-spectrum antibiotics to patients you don't even know are infected, much less severely infected. And is there any evidence, and should we be doing this? Should we be giving broad-spectrum antibiotics to sore throats? Because that's kind of the situation we're going to be in the US, and I think a lot of the world. So please, who's going to take this one first? John.
I guess I was talking to Simon last night over a glass of wine about this panel, and I guess the antibiotic story is fascinating. If you look at the impact of penicillin on survival of pneumococcal pneumonia, that was probably the only magic bullet we've had in our lifetimes. The absolute mortality dropped by 7% with patients who got penicillin and those who didn't. This is all retrospective cohort studies. It isn't a prospective study. So if you account for half that effect size, in terms of for the poor methodology, there's still a 3.5 to 4% absolute risk reduction from one drug, which is remarkable. And that's an important consideration, thinking about how important it is. When you look at those data, the death rate from pneumococcal pneumonia was unchanged in the first 24 hours, whether patients got penicillin or not. And that's purely an expression of host response. Those who are programmed to die will die, as Mr. Singer said this afternoon. Those who will respond to antibiotics in the first 24 hours will respond. But once you get past that stage, when you kill the bugs, you're now getting the latent host response phase. And that's how they work. And that's, I guess, how I interpret using antibiotics in that context. In answer to your question, should you give gorillamycin or meropenem to everybody with a sore throat? Well, then the answer is, I don't know. It makes intuitive sense, particularly in the days of emerging resistance organisms, but I don't think you'll get much more or a better treatment effect than you did with penicillin and pneumococcus. So it's a very grey area. It's like firing a shotgun into a flock of birds. And at the other consequence, you may generate resistance in patients in whom those drugs are very effective. So I think the historical context tells us that giving antibiotics early to patients with a high likelihood or a certainty of an infectious process, that without switch, the patient will die, it's a no-brainer. You should give it. You should go hard. You should go early. And I think you should use an antibiotic which is available, which is most effective on a population basis. But then reassess it earlier on rather than going on ad nauseum. The patient who's got a bit of a temperature 14 days after a bowel resection is a different beast.
Anyone else want to? Yeah, please.
Mervin's got an opinion.
Oh, okay. I think the whole antibiotic story, it's a wonderful example of gross dissemination of propaganda over truth. If you actually look at the evidence, there's probably an equal and opposite literature against the efficacy of antibiotics, and it sort of echoes what John was saying. So I agree with him. You don't want to deny a patient an antibiotic, but to pretend they're a panacea is, I think, naive, simplistic, and I think oversold. And you've got, dare I say it, these rather sort of hard-to-believe straight-line relationships. Every hour kills you, blah, 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 or delay. It's not true. Because you don't even know how long the patient has been getting ill for before time naught, the clock starts. So, there's a huge literature that says the opposite. I think, certainly in the UK, a bit like the US, you were saying, the Department of Health are trying to drive, you should throw antibiotics at everyone. And I was on a sort of panel of Royal Colleges in the UK, and even the gynecologist was saying, that's a bit stupid, isn't it? Oh my God, the gynecologist.
No gynecologist in the room.
Yeah, no gynecologist in the room, I trust. But,
My wife's a gynecologist.
Well, none, but nobody will admit to it. But I thought, prescient foresight by a gynecologist. So the point is, we're looking, when you think about it, it's a point I made earlier, it's only a tiny minority of patients with infection who ever get near an intensive care unit. And clearly, these are the ones we want to identify, we want to treat. Certainly, if you're going to start antibiotics, because of paranoia, fear, whatever, start them, but then stop them quickly, because usually within a day or so it becomes apparent they're not infected, number one. Number two, most bugs in most parts of the body, outside cardiac valves and bones and stuff, 1 or 2 doses of antibiotics is probably sufficient. It cures gonorrhea, it cures UTIs, there's stuff on pneumonia, 1 dose or 3 doses. Meningitis in Africa, 3 doses, or 1 dose actually was good enough. So, again, we're brought up thinking, oh, we've got to give a week, 2 weeks. Bollocks.
Catherine, you want to say something?
The world is running out of antibiotics, and I think we have to be very much more responsible about the way we prescribe. And I think, going back to Paul's point, look at your patient and look at their risk factors. If they clearly don't have any risk factors, I think you can be conservative. If they're critically sick, yes, go in early and stop early.
I might take a slightly different view. If it's possible to keep agreeing with everyone whilst disagreeing with them. It's a very interesting question, because antibiotics is really the only treatment where we're prepared to subject an individual patient to a potential increased risk of death because we're worried about an effect that we might have in the future on someone else. There's no other treatment where you think, I'm not going to give this person the best possible treatment for them as an individual in the hope that I'll benefit someone else who's totally unrelated at some point in the future, which is what we're doing because we're so worried about antibiotic resistance. In the Surviving Sepsis campaign second iteration, I was at the SCCM meeting presenting something or whatever, and I was asked by ANZICS to go to the meeting. And Julian Bion said, can we talk about SDD, selective decontamination of the digestive tract? And everybody went, oh, it's time to call an end to this, isn't it? And Julian said, but hang on, there's more evidence for SDD than all these other things that we've just said are going to be in the guidelines. And everyone said, well, we don't really want all that, do we? Isn't it time for lunch? And the chair said, we'll have a vote on a bit of paper. Everyone write yes or no on a bit of paper, and that was it. So SDD was thrown out, despite the fact there's more evidence for SDD than there is for many of the things that are in the guidelines. So there's this really bizarre thing that goes on once you raise the idea of antibiotics. And the other thing that I'd like you to consider is, what is the number needed to treat? Now, Mervyn, I agree with Mervyn. We probably don't know. But there was a thing I read. I'm fortunately have this problem with my brain. I read everything I can lay my hands on. And there's, this cholesterol story, ezetimibe. Okay, there's recently been this wonderful paper that shows that it reduces cardiovascular risk. So if you treat 100 people with this drug for 10 years, you will prevent 2 cardiac events. Okay? Now that is going to be given to everybody. So the number needed to treat is 50 odd. So I express that as 98 people have to take this drug for 10 years for no benefit whatsoever. So I think antibiotic resistance is a big problem. We have to consider that. We don't know what the benefit of it is. But I think the chance of us doing a trial is zippo, isn't it? I mean, there's no way we're going to be able to do any research on it. We're not duration, yes. Yeah. De-escalation, yes. Withholding antibiotics completely from someone who you think has sepsis is just not going to happen. So I think we do have to treat early aggressively, and we should focus our efforts on de-escalation and the duration, which I agree with you. I keep stopping antibiotics. When someone's sitting there, even if they've had septic shock, and they look completely well, and they're drinking their cup of tea, and they're ready to go to the ward, they don't need, and they've grown something in their blood, I really don't think they need week, 10 days, 14 days of antibiotics. I think if we cut down on the infection, and of course, we have some funding to do an SDD trial, so hopefully that'll happen.
Do you want to summarize antibiotics, Chris?
Well, it's probably not just antibiotics, but it sounds like there's lots of people amazed by the knowledge and opinions of the people on stage, but there is maybe a feeling that the everyday doctor is maybe getting a little bit confused now by how to manage sepsis, and you know, what can the doctor on the street actually do? So that's maybe something we can explore a bit further, Scott.
He's busy being the waiter.
He's quite busy there lubricating the panelists. It's important to have well lubricated panelists, that's what I always say.
All right, now
That's a big
let's
deal.
get to the part we've been waiting for. Paul, you know it's been coming. All right, guys, I'm confused. What the hell should we be doing with fluids and sepsis? I thought I knew 10 years ago, and now I honestly have no idea. And why don't we start off there? Paul, should we be giving patients 6, 7, 8 liters? Is that a good thing?
So I think it's important to realize, and we need to say this clearly, sepsis is not a fluid-depleted state. People with sepsis do not have diarrhea, they do not have cholera, they do not have diabetic ketoacidosis. They are not volume depleted as a general rule. They are venodilated, so their venous pool, normally about 70% of your blood in your venous system, you become profoundly venodilated. You have some degree of capillary leak, but intrinsically, it's not a volume depleted state. Secondly, most patients who are septic are not volume responsive. So the only reason to give fluid, there's no other reason, unless you're drunk, is to increase stroke volume. That's the only reason to give fluids. And if you do not increase stroke volume, it serves no purpose. So we know that only about 30 to 40% of patients who present with sepsis will respond to fluid. What's even more shocking is the duration of the effect is very short-lived. The duration of the hemodynamic effect is very short-lived. So what you're doing is you're shifting the fluid from the bag through the circulation into the interstitium and causing profound tissue edema. It's a condition called iatrogenic saltwater drowning, and that's what we do to our patients. There are some patients who will be, you know, a little old lady, she's septic, she's had poor oral intake, she may be a bit volume depleted. You give her a little bit of fluid, but this idea of giving a 30 cc volume challenge is outrageous. It defies understanding human physiology because, in fact, we know above a CVP of 6, your diastolic compliance of your RV goes up significantly. You increase diastolic distension, release of atrial natriuretic peptides. You screw with your glycocalyx. The fluid goes into the tissues. A high CVP actually impairs capillary and microcirculatory flow from back pressure. So volume overload is a bad thing, and I think we kill more patients with fluids than we help. But I actually don't have strong opinions either way.
Always taking that middle line, Paul. Catherine, why has no one regarded the FEAST trial as applicable to patients in the US and the other countries that are not cash-strapped?
I think it was such a surprise to ourselves, so to the rest of the world, obviously it was even a greater surprise. How could a trial come up with such a result? I mean, we didn't expect the result, and I think obviously people will want to do a forensic search of, you know, is this data flawed, and so we have published not just obviously the New England Journal paper, but a whole series of other papers, just really responding to some of the questions that we've been asked, and you know, who was in the FEAST trial, what was their mode of death, and I think the second paper is probably even more important than the first paper. The doctors at the bedside saw patients get better. They felt that they were doing the right thing. They felt more confident about giving fluid boluses because they reversed shock. And they saw children warm up, children wake up, and they passing urine. They looked so much better after a fluid challenge, whereas the children who were in the control group, they looked so sick, and they remained sick for the rest of the day, in the hibernation state, if somebody would like to say that. But actually, that early success that the doctors saw did not translate to a mortality benefit. In fact, actually they went back into lethal shock fairly rapidly after that. And I think that tells us a lot about physiology. To reproduce that experiment, I think, well, it wasn't an experiment, it was a trial, but I think that it's a very, very important thing. That I think that fluids have a role. Too much. We were only giving 20 mils per kilo. When you think, well, actually, you probably weren't giving enough. When we actually increased the initial bolus from 20 to 40, although it wasn't statistically significant, you saw a dose response that actually had an even worse mortality after that. So it wasn't, although we weren't filling them up enough, that actually just giving rapid, and that's over an hour compared to what's recommended in pediatrics, it's still harmful. So I think doing anything very rapidly in a critically sick patient who you can't give any other support to, I think is a very important observation. And whether the actual whole resuscitation, and whether you define that if you give fluids and they don't seem to respond, then you give pressors, whether actually that they may need to be brought in earlier, because as you say, they're not fluid deplete, they're just all in the wrong spaces.
Yeah. Fabio, why don't we have ladies go first?
Yep,
go first.
Kathy, don't you think that we were discussing in the Latin American Sepsis Institute with some pediatricians about how to manage this in Brazil? And I already asked you, don't you think that the setting is different? I mean, you have 60% of malaria patients. You have, I don't remember how many, but there were a lot of patients with less than 5 of hemoglobin. And all these children, all know, but vast majority of them were late in the hospital.
How do you know that?
Well, no, I think, because coming from Brazil, I can say that in Brazil they are late in our emergency department, so I can imagine that the same thing happened in Africa, or maybe it's even worse. So don't you think that this is the major problem? I mean, I agree completely that in Africa, for malaria and people if have less than 5 of hemoglobin, you should not give fluids very fast. But does this fits to the rest of the world?
No, I mean, we have looked at all of the subgroups, and we had children who had normal hemoglobins, and their response was exactly the same. So you say, oh, well, 60% have malaria. That means 40% of 3,000 children didn't have malaria, and they did worse. So those who had bacterial sepsis did it particularly badly in fluid boluses. So although we've not directly published that result, there is very large subgroups who would have relatively similar conditions as what you see.
And how about the delayed intervention?
Well, it's very difficult. I mean, you can't. We didn't actually collect data on when their illness started, but on average it's usually 2 to 3 days, which is usually the same as many patients here. Some of them were from regional hospitals where they had come from fairly far away, but there were still quite a lot of children from the urban areas, particularly in Malago.
You want to say something?
I think Paul is right, but he's wrong. Sorry, Paul. I think every septic patient merits a fluid challenge. You know, and I think the crucial point, which I totally agree with Paul, it's use your brain, use physiology to determine that. I agree with this sort of mentality of, oh, let's give 30 mils per kilo and see how drowned they are. It's a bit brainstem. You know, our unit policy, we give 200 mils as a challenge. Look at the response. Ideally, I agree with Paul, we look at stroke volume. But if you don't, look at the change in the CVP, other markers. And then if there's good evidence, physiological evidence, that they responded and there's still room to go, you can repeat the 200 mil challenge. And you can give it over 5 minutes, wait 10 minutes to look for the response, repeat. And so it's a, dare I say, a more logical, physiological way of titrating the fluid. You don't want to give too little, you certainly don't want to give too much. And I think, unfortunately, again, some of the points that was made earlier about the guidelines, they dumb them down too much and they pick sort of completely arbitrary numbers, or get your CVP to 8 to 12, or if they're on a ventilator, get them above 12. There's no physiological basis for that, and in fact all the evidence shows the opposite rather than that. So unfortunately, I think we've been misled as a community, and I think a more tailored approach to the patient is what we need to do.
John, you've been hankering to say something.
I don't want to sort of state what's been said before, particularly what Kath has said so eloquently, but I implore you all to read the paper in Public Library of Science, PLOS, of the mechanisms of the FEAST trial. It already provides enormous insights into what they saw, and I reviewed that paper a number of times and insisted it got published because of its importance. One of the criticisms by high-income ivory tower people was that, of course, that's Africa, and we have ventilators, and we have Swan-Ganz catheters and lactate measurements, and of course, this would never happen in our practice. And that somehow the harmful effects of fluid loading would be mitigated by the addition of ventilation and catecholamines and all those things. I think is very arrogant and, again, oceanically stupid. The physiology is consistent, because what you think you're seeing from the FEAST trial were patients who were maximally compensated. These kids had been sick for a while, they'd come across a difficult access to hospital, and they were maximally compensated. And what they had was febrile hypotension with compensated shock. Now, we see very few patients like that. Most of them come in and they're resuscitated early. But this is a good example of how you're now overriding maximal endogenous physiological systems by intervention that ultimately is harmful. And so if you've got a patient who's literally hanging on by her fingernails, okay, be very careful, because you start drowning them in fluids, even if you have rescue ventilation and rescue catecholamines and rescue ECMO and rescue prayer, okay, it's going to be difficult. And you may well be adding to the patient's harm. And so the notion of, and I disagree slightly with Mervin's point, that every patient should have a fluid challenge. What you're challenging isn't the patient, you're challenging your own intellect. Because it needs to be contextual. You know, squirting in 500 mils of starch or albumin or whatever it is, looking for an effect which is almost impossible to quantify in any meaningful fashion, unless you're going to stand there at the bedside and do it for the next couple of hours, is hubris. So really think about it very, very carefully.
Please, Simon.
So I think although John and I jointly wrote the editorial to accompany the mechanisms paper for Kath's wonderful paper, and I do think it is very interesting, because the cause of death was cardiovascular collapse. Yeah. It wasn't respiratory failure in fluid overloaded kids, it was cardiovascular collapse. So it's, how do we explain? Now, I have a different take on that. I think from where you think it's rapid resuscitation of compensated shock. The other possibility, which I think is quite interesting, and you were at the round table where Luciano Gattinoni was discussing his work, animal work, but I don't think entirely relevant, is that your patients were quite acidotic. And then they got rapid boluses of two fluids, both of which make you more acidotic. Normal saline or albumin in essentially normal saline, in a situation where you could not rescue them. Now, that's very different, and I'm more biased towards the acidosis hypothesis, that you had very acidotic kids, you made them more acidotic, and you didn't have the ability to compensate. There are at least two proposals for restricted fluid trials currently. Anders Perner, who's, I'm not sure if he's in the room, but he's certainly at the meeting and speaking, and the Scandinavian Trials Group working up a proposal. I'm not sure quite where that's at. We are in Australia and New Zealand to look at restrictive fluid strategies in critically ill patients in general. There's only one trial really that's done that, which was the ARDS network FACT trial, which suggested a reduction in ventilator or an increase in ventilator-free days with a restrictive strategy, with the caveat that there's another paper published that a lot of people don't know about, suggesting that the patients who had the restrictive fluid strategy have worse long-term cognitive outcomes. So how do you balance ventilator-free days, which is a bizarre concept that it's a bit hard to work with because it's been defined 24 different ways, exactly 24 at the last count, versus long-term cognitive deficit? If you ask the patients, and we're just currently working on this what do the patients think are the right outcomes? Not what we think. What do the patients actually want out of intensive care? And certainly in Canada, where John Muscaderi has done some work on this, poor cognitive outcome is the one thing they don't want. So the fluid issue, I agree. I agree with it. Giving fluid to people who are vasodilated, it defies logic. And we do give fluid as a carrier for noradrenaline. I think that's the way to give fluid to people with septic shock.
All right, well that sounds good, but let's go rapid fire down the panel. The fluid we're going to give, if we're going to give any, does Balanced Solutions have any weight? Do we care? Are we killing the kidneys? Why don't we start off with Mervyn and go all the way down the line? Please keep it brief. Mervyn?
Couldn't give a toss. Whatever you want to give.
Can't be briefer and better than that. Paul?
Yeah, I say give a balanced salt solution because normal saline is nothing physiological about it. Fluid has a sodium of 154. It causes all bad things. So unless you have acute brain injury, I think a balanced salt solution is the way to go. And there is a propensity match study which shows comparing normal saline to balanced salt solutions in patients with sepsis, whatever that means.
I'm glad Paul's keeping it brief, Scott.
Well, watching Mervyn's face makes it okay.
Yeah. No, but I won't be rude.
Well, I mean, you want to?
Yeah, no, it's not. It's an association study, which is a year before and a year after, and there was no mortality difference. There was a bit of an improvement in renal failure, and so many other things can happen in a year. You change your house staff. So I think until the trials are done, that's why I don't care what you give until I've got good data to tell me I should change.
Coming from a country with middle resource, I would never give balanced solution until I see a trial comparing balanced solutions with ring lactate and not saline. Because I don't think that even with saline, it's going to be difficult to show good outcomes. But against lactate, against ring lactate, I doubt.
Simon?
Well, balanced, buffered crystalloid solution first, maybe a little bit of albumin, maybe starch if you want to kill the patient. That's about it.
Fluid's a drug, and I think people, as John has written, and I think people have to respect it. And I don't know how 0.9% saline ever got the name normal saline.
John, finish us off on this topic.
The question was specifically about balanced versus saline.
Balanced solutions in general, do they have any utility? Are we saving the kidney, or are we?
Well, we'll tell you in 3 years' time when we do our big trial. But in answer to your question, if a patient was profoundly acidotic and hypovolemic, I'd probably give some hypens or ringers lactate or plasmolite balanced. If I had that information, if the patient was alkalotic and hypovolemic, say from upper GI losses, I'll give saline. If the patient was septic and truly hypovolemic, which is very rare, I'll probably give a bit of either of those two fluids and some albumin.
All right, fair enough.
And starch?
Yes.
Starch I'll give to someone I didn't really like.
You give it to Bolt.
I'll give it to Joachim Bolt, that's what I'll give it to.
What? Oh, Chris, please summarize.
So I've got one tweet here from Chris Cole at Doc on Skis, which I've just got to say. Balanced crystalloid is better than normal saline. Is urban myth received wisdom voodoo bollocks? So there you go.
Couldn't hear that.
I didn't hear that.
No.
Yep.
All right, and moving right on. That's all you got for us, Chris?
Yeah, that's all for now. There's plenty others I can't say.
I bet. Let's briefly talk about vasopressors. I think everyone has a preference. Let's ask this. Is anyone recommending dopamine as a first undifferentiated choice anymore? Is that gone? Can we just not even discuss that? All right, good. Let's leave that on.
For people you don't like.
Yep, absolutely. So norepinephrine or epinephrine as the first choice vasopressor for sepsis. Let's have someone weigh in. John, I know you have opinions on this.
I'll start. I mean, it's noradrenaline, Scott. It's not norepinephrine.
Oh, please don't start this again. You're in my country, my friend.
Well, I have an adrenal gland. You have an epinephrine gland, okay?
Deep breath.
Cheap shots at the
You're watching,
moderator.
you're
That'll
watching
get
for
more
that. I'm
booze.
sorry, I was waiting for that. Anyway, look, you know my views on this. I view catecholamines that we give as infusions as supplementation of a inadequate or failing endogenous system. It doesn't mean to say that you go open slather. Noradrenaline, norepinephrine, is the neurohormonal vasoactive agent acting at all levels of the autonomic nervous system, cardiac, veno, arterial, under situations of homeostasis. And that's the drug that you would use if you're going to augment failing systems. Epinephrine, adrenaline, endogenously acts by releasing noradrenaline from the presynaptic terminals under the influence of the adrenal gland, and actually acts indirectly by releasing noradrenaline, in addition to a few specific metabolic effects which are really designed to protect the host. The most important of which is the generation of lactate, and the generation of tachycardia, and the generation of hyperglycemia. So it is the true stress hormone. Whether you use either adrenaline or noradrenaline doesn't matter, as long as you can accept that the patients who get adrenaline or epinephrine will tend to have a lower pH and a higher lactate. That will be short-lived and resolve, provided the patient gets better. So in that context, I would use noradrenaline or norepinephrine as the first-line vasopressor, as I have the last 25 to 30 years. It's interesting to note that in many parts of the low-income world, noradrenaline isn't available because it's too expensive. This is the one reason why I had problems with the Sepsis guidelines, because they relegated adrenaline down to a toxic drug with a bad profile, only to be used for refractory shock, which is abject bullshit. And those guidelines had a significant impact on the use of drugs in low-income countries like South Africa. And that was based on really a misunderstanding of the evidence. So the two drugs are interchangeable. Adrenaline is probably a little messier in terms of metabolic status if you are fixated on lactate, but probably eco-effective. And as far as the rest are concerned, dopamine and synthetics, you can forget it.
Yeah. Anyone have a dissenting view or a differing opinion? Please, Murph.
Yeah. Actually, going back to the norepinephrine, noradrenaline, there was a lovely paper a few years ago in the British Medical Journal. Pharmacologist wrote, the hormone is noradrenaline, the drug is norepinephrine. So, hey, you know.
Thank you.
You're welcome. So you're right.
Scott? Oh, yes.
Yeah, sorry.
There was more to it than that.
But basically, catecholamines are poison, period. You know, and there's loads of association studies showing the more you give, the worse the patient does. There's a huge list of harm that these drugs give, and because we don't see them at the end of the bed, we might see the tachyarrhythmias, the black fingers and toes. There's a whole host of other things that they do. So clearly, if you need to use something, you need to use something. Whether they're the best, there are a number of studies at the moment seeing if alternatives are better, but clearly try and avoid as big a dose as sometimes are given. You know, again, moaning about guidelines, but to pick an arbitrary blood pressure and say, oh, this is a target you should aim for in all of your patients, is patent nonsense. You should pick the blood pressure that suits the patient. Sedation, you know, well, slightly tongue-in-cheek say the best treatment for septic shock is stop the sedation. Yeah. You know, and a lot of the time, hey, the blood pressure comes up. So, you know, there are things we can do to minimize the dose. So these are, like everything we've said, you know, fluid, whatever we do, everything is a poison when given in excess. So if we're going to use it, keep the dose as low as possible.
All right, Flavia.
No, it's okay.
Oh, no, okay. All right.
So I was just going to make
go
two
for it,
points. Firstly, I mean, alpha agonists venoconstrict and increase venous return. So they actually increase preload. They increase return to the heart, and they recruit blood without giving fluid, which leaks out. So you're giving a enduring, fluid lasts 20 minutes, 30 minutes. You're giving an enduring drug which maintains preload. Secondly, the earlier you give it, the better. There is this perception you can't use norepi because you need a central line, and no one's going to put in a central line, so we'll just give them fluids. But as you know, Scott, that's not true. You can give through a good running line, you can give norepinephrine. So you can start it off early, peripherally, and you don't have to give the excuse that you need a central line. And I think that's an important obstacle to overcome.
Absolutely. Paul Mayo's study was just published adding to the data that peripheral pressors are okay, and that just came out. We only have about 8 minutes left, and what the audience on Twitter has been clamoring for, because everyone on this panel has basically said, be an expert critical care clinician. That's what's come out of this panel, and that's true. And in the hands of anyone on this panel, I'm sure patients will get great sepsis care. But there are other people in the audience who do not have this expert level of critical care, and they want to know, are there any simple take-home messages for sepsis care they could use? Because now we're saying the guidelines don't work, we're saying broad-based strategies don't work, but yet they still want to go home with something. And let's just go down the line, starting with Mervyn. Mervyn, what is a simple guide you give to non-critical care experts?
No, I think guidelines are what they are, guidelines. You know, so therefore you've got something to hold on to, something to follow, but you should still look at the patient regularly and see if the guidelines, you're following them, the patient doesn't do what they say, or you can apply them to your setting, so don't drown them with fluid, etc., etc. But if they're not following the path and you think, hey, let me try something different, use your brain to the patient in front of you, because thankfully, patients don't follow the rules. If they did, we'd be out of a job. A computer would be doing our job for us. So I think that's the art of medicine. So we have to combine the science, we have to give a basis, an infrastructure, but at the same time, we have to tweak, and that's the art.
Paul?
So I think probably the most dangerous thing is to measure the central venous pressure. I think it should never be measured because it is a remarkable response. A normal CVP is 2. You need a pressure of 2 in your atrium, otherwise you're not going to have venous return. And what happens when people measure the CVP, they think it has to be 8 or 10, and it's really remarkable in the process. In Prowess trial, in that placebo arm, every patient had a CVP of 10. They really didn't do an experiment because they gave fluid to cause a CVP of 10. It's profoundly unphysiological. And the only way to stop it is never, ever, ever measure the CVP ever again. Period.
All right, Flavia?
I'll train your nurses in the wards and in the emergency department to recognize SIRS criteria and to call a doctor to see if the cause of the SIRS criteria is an infection. And if it is, collect blood samples, look at the lactate, give some fluids. If you're in the ICU, don't give fluids, make some fluid responsiveness test, and give a little bit of norepinephrine, low sedation, and let your patient rest.
Beautiful. Simon?
So I agree, guidelines are guidelines, and if you are really, I don't think there's likely to be many people in this room who are completely non-expert. But guidelines are guidelines. We pick them apart, but they're put together, and obviously the Surviving Sepsis Campaign guidelines are currently going through the next iteration and will be coming out sometime in 2016, and the process seems to be reasonably robust. So I would say if you really thought you didn't feel comfortable, you should be at least following the guideline along, but please apply some common sense. If the patient is looking well and improving and passing urine and warm, and they've got some number that doesn't look right, don't try and fix that number. Okay, you really must have some clinical acumen. The problem, it's very hard to get years of experience quickly, but you know, hopefully you come out, and if you really, you know, we all make mistakes, and I've often tell people that intelligence is the ability to learn from other people's mistakes. You don't have to make them all again yourself. But so I would say if you really feel out of your depth and uncomfortable, follow the guidelines. Just don't try and fix every number if you can assess the patient is on the right trajectory. If they're on the wrong trajectory and it's all going wrong, then you should be definitely getting an expert in.
Catherine?
You were the lucky ones. You came to an amazing conference and you're going to go home and be able to talk about it. And I think if what you've learned at the conference, you feel like it's changed you and you'd like to change your practice, it sometimes might be very difficult to do that as an island, as an isolated person. And because the lectures that have been given here are all available, you might want to sit down with your colleagues and say, hey, hang on a minute, I've been told not to respond to every lactate. And just come together and sit down and say, how do we, because there's nothing more frustrating than you thinking, well, I'm going to just ignore that, and then the next person who comes on in the shift then starts pouring in fluid. So to actually have a discussion when you go back to your own institutions and say, I think I've learned something, do you want, let's discuss that. And I think if you feel like you can get some agreement, then you might benefit from.
Which deserves a round of applause for you and for the organisers who put it all. That's you.
No, I was about to say that is an incredibly SMACC message. So, John, please.
You can come back next year, Catherine.
I'm not. Again, as usually, I agree with Kath, who's one of my biggest fans, in terms of the erudite conclusion for that. What I would say, just as a slightly, and all my colleagues here, I would agree with entirely. This is a really serious disease. Don't kid yourself. If you're not an expert or working in an expert area dealing with patients with severe sepsis, then it behoves you ethically to make sure the patient is put into a place where they can be managed properly. Now, that's the important thing. This is not a disease or a syndrome for amateurs, even though it's widespread. And unfortunately, certainly in my country, will be increasing in our elderly populations. Let's not forget that the biggest burden of sepsis burden is carried in low-income countries, like Brazil and in Africa. There hasn't been a new anti-malarial drug or TB drug in 50 years. That's a violation of human rights. It really is a problem. We sit here talking about monitors and lactates, but really, where the burden is carried, there's been this refusal to acknowledge that. The guidelines are a good initiative with good intentions. Guidelines are designed to prevent disasters, but inhibit excellence. So whilst you can actually raise the standard to a level which is safe, you've got to think beyond that to make sure that you're delivering the best critical care, the best excellence to the patients. But make sure that that is not that is generalizable to rank and file people across the country, and more importantly, in areas of the world where the sepsis burden is the greatest, namely in Africa and in the developing countries.
Beautiful. Chris, finish us off.
Okay, so I've just got a couple of things that I'd like to comment on from the Twitter sphere. And one has been, there's been this general dissatisfaction with how complex and confusing that is, but unfortunately we don't get to design the human body, do we? But there has been a lot of people saying that they've been inspired to learn more physiology, that John Myburg is the Clint Eastwood of critical care, and that, Mervyn, there is at least one gynecologist in the room. So
all right, and we are...
What's he doing here?
One gynecologist.
He got to the wrong room.
Yeah. We are perfectly on time, and at this point, can we have an enormous round of applause for our incredible panel? Thank you all. This was spectacular.